Hi, so I'm Jessica Metcalf. I'm an Associate Professor of Ecology, Evolution and Public Affairs at Princeton University. In a way that cuts to the core these days, my health is your health, and your health is my health. Infectious diseases, like the pandemic virus, starkly illuminate how we share health. I teach epidemiology, which ranges across all of health, including chronic conditions and accidents. We spend time thinking about how to weigh the evidence that a particular exposure, perhaps a pollutant or a dietary factor, causes a particular health outcome, perhaps a respiratory condition or a chronic affliction. Infectious diseases are different. The cause is also the effect. My being sick means that you could get sick. This means our risks are shared. It also makes for a very different world of risk management. We know what reduces risk in this pandemic: physical distancing, wearing masks. But if some people don't or can't work to reduce transmission by physically distancing or by wearing masks, the risks are a moving target. And by moving, I mean going up. The problem isn't like introducing mandatory seatbelts, for example, which will change the risk of fatality in car accidents in a predictable and usually rather steady way. I have a colleague who built an extraordinary SARS-CoV-2 surveillance network in his community. At a recent meeting, someone said to him, "Only 2% infected. That's good, right?" He told me, "I didn't know what to say. 2% of your house is on fire. Is that good?" I started by saying, my health is your health. It is, but also it isn't. The risks in this pandemic disproportionately land on people who can't afford to take the steps required to reduce infection, who can't work from home, who can't just order food to be delivered. In the US, socioeconomic and racial disparities in COVID-19 deaths have been enormous. In Mumbai, estimates suggested that up to half the populations of neighborhoods classified as slums had been infected, while in affluent neighborhoods only 100 meters away, proportions were closer to 10%. Sick pay and sick leave, labor rights, economic safety nets, making these generally available could reduce the extraordinary inequities that have marked this pandemic. And because even despite these inequities, our risks are shared, they could also reduce all of our risks of infection. The backdrop of inequity that marks our societies makes delivering public health hard. But public health has some really incredible tools. One of the most striking is undoubtedly vaccination. If I'm vaccinated, I'm likely to be protected. But what is more, for many vaccines, I'm also protecting you. And this is important because you might not be able to receive the vaccine, for example, if you have certain health conditions, or because you didn't have access to care when you were eligible. Vaccines are an incredible social good. If we take the example of the infection I've worked on the most, which is rubella, infection during childhood results in a relatively mild infection, a fever, a rash. Usually there are very few sequelae. And once you've been infected, you're immunized, so you're protected for life. The reason that rubella is a public health challenge is because if women are infected during the first trimester of pregnancy, their child can be born with congenital rubella syndrome. And this involves deafness and blindness and mental problems. So by vaccinating your child, you're not particularly protecting your child, you are protecting everyone that child will encounter who might be pregnant in that first trimester of pregnancy. There's a story of Jean Tierney, a Hollywood star of the 40s, who had a very difficult life with many mental health problems. Her first child was born with congenital rubella syndrome. And years later, she met someone who said, "I was such an enormous fan. I was in the Navy, I was in quarantine. I snuck out to get your autograph." So she met the woman who had resulted in the birth of the child with this affliction. Agatha Christie later used this as a plot in one of her murder mysteries, The Mirror Cracked Side to Side. Vaccines can seem strange. After all, they're a treatment you give to apparently healthy people. But the individual and society benefits, I think, are potentially enormous. Vaccine hesitancy is a huge area of research, but I think there's much to be done to harness our desire to avoid potential harm to others, even beyond considering our own health in tackling this question. Vaccination made possible a huge triumph of public health, the eradication of smallpox. Smallpox was a directly transmitted infection like SARS-CoV-2 with a devastatingly high infection fatality ratio, perhaps as high as 20%. Infected individuals who didn't die were often left with disfiguring scars. Huge global efforts coordinated by the World Health Organization and aided by a thermostable vaccine, idealism and a united sense that this disease should be eliminated led to eventual triumph in 1980. It's estimated that the United States recoups the investment it made in smallpox elimination every 26 days. So it's an incredible and extraordinary common good. Since the late 1980s, the World Health Organization has been aiming for polio elimination. I grew up in many countries in Africa, and I remember my father pointing out children on crutches with twisted limbs and saying, "See, there are no children younger than 15 with that affliction." And it was true, and it was because younger children will have had the vaccine and thus been protected from this infection. And there have been huge reductions in polio incidence around the world. Elimination has proved more elusive. It's often said for disease elimination that the last mile is the longest. The hardest people to reach are likely to be the people who are left at the end. But the gains have been remarkable. Whether elimination is the goal or control, i.e. reduction of incidence to very low levels, vaccines are an undeniable social good and have driven huge increases in life expectancy globally over the last years. For the COVID-19 vaccine, globally equitable vaccine distribution is moving rapidly up the agenda of things we should be thinking about. It's important to note that we still don't know the degree to which the various SARS-CoV-2 vaccines block transmission. They might just stop us from having symptoms or getting sick, but we might still be able to give the infection to other people. We don't know yet. However, it seems likely that at least some transmission blocking will occur, which will make these vaccines another key tool for reducing the number of infections. However, if you vaccinate all your citizens, but everyone in neighboring countries is vulnerable, you still have a problem. Introductions of the disease are likely inevitable, so the infection could flare up again. Infectious diseases, by their nature, create a shared agenda. In the last decades, we've advanced so far in our scientific understanding, from prevention to treatment of infectious diseases. We've made so many gigantic technological leaps. We've been able to make a novel vaccine in an astonishingly short amount of time, and this is an incredible feat and a huge triumph, and a testimony to all the remarkable scientists working on this, and all the people who volunteered to participate in the trials. Yet, despite all of our advances, all of our progress, all of the technological tools that we had, here we are, faced with the pandemic, which has disrupted everything. Technical fixes are not likely to be enough alone. There's rarely a silver bullet solution to a public health problem. Every little bit, from sanitation to masks to advances in care, is likely to help. And I think this brings us to a final way in which the commons intersect with our lives in the context of infectious diseases in this pandemic. We're all in this together, so everything that happens to one of us can help the greater good of all of us, by helping us to better understand this common threat. I think we should not squander a single opportunity to learn, to better understand what slows transmission, what treatments work best, which vaccines are most effective. We learn things all sorts of ways. Early on, doctors were sharing huge WhatsApp chains of what they'd tried, everyone figuring out together from their observations what might work best. As an epidemiologist, reports of case numbers through the Johns Hopkins dashboard at first, and then other sources like the New York Times, were absolutely invaluable to my community as they raced to pick apart what the transmission rate of this infection was, how far it might spread, and what might work to slow spread. Early crowdsourced data were amazing, and the efforts of openness and sharing of data across the research community has been absolutely inspiring. But of course, early data also had biases. Of course they did. Not everyone was tested, and so on. In our efforts to learn from our common experience, better measurement is key. Better measurement of cases, but also of our immune status. My colleague Brian Grenfell and I feel strongly that a global immunological observatory could really contribute to the common good. With a better understanding of who is and who isn't protected against various infections, we could much better understand how diseases might spread, where they might emerge, what the risks are. And this is a commons that we could all contribute to and that we are all part of. Beyond that, every intervention we do, every time we open or close schools, every time we change the rules about gathering sizes, designing these interventions systematically so that no action is wasted, every step teaches us something, could be part of an enormous commons of research. Anonymity, transparency, equity and access to data, sensible and equitable design of interventions, all these issues are crucial, but the benefits could be so high that I think the effort is well worth it. Sigmund Freud's favorite daughter, whom he called his Sunday child, died of the 1918 influenza in 1920. Even though we have astonishing tools like the vaccines and have made remarkable progress in understanding this infection, this pandemic could take longer to end than we like. Or we might be out of this much faster. It's very hard to tell. So much hinges on politics and politicians, so much on viral change and immune escape. All of these elements are hard to predict. But we should absolutely keep driving to keep transmission down, to help each other keep transmission down, and to keep learning from what is happening. For this pandemic, but also for the next one, because this will not be the last pandemic. A collective threat calls for a collective effort to help us and each other get through this difficult time, and second, to learn everything we can for this one and for the next one.